So now we're going to talk about the rest of the arteries and the aorta beyond the territory that Dr. Mashley just talked about. So in terms of vascular surgery, if you'll go to the next slide, please. And basically, my goal for the audience here is to learn the difference between aneurysms and dissections, because frequently people confuse the two. I will show you the distribution of the arterial pathology in vascular EDS, Loeys-Dietz, and Marfan syndrome, and based on our recent data. And then I'll talk about what vascular surgeons use in our toolbox in terms of repair principles and how we approach repair, and that should include embolization. You'll hear that term, stenting. These are both endovascular methodologies. And then I'll talk about the open surgical repair. And I'll briefly touch on management by location, and then we'll have time for questions. Next slide, please. We'll start with aneurysm. When you hear the term aneurysm, what that means is that it's dilation of the artery to more than 1.5 size of normal. So every arteries, there are some set criteria for what makes a normal artery. And then if the size grows to 1.5 times that, then it is an aneurysm. So for example, when we talk about the abdominal aorta on average measures about 2 centimeters. And so if it's 3.5 centimeters, then that is considered a small aneurysm. It doesn't mean that it has to be fixed at that size, but it just means that it is an aneurysm. And usually aneurysms have no symptoms unless they're very large and they're causing compression on the tissue around them. They can come in different shapes. They can come in the fusiform shape that you can see here on the slide, or saccular, which is more like a ballooning off the wall itself. And then obviously we care about them because they can rupture, and that's when they cause the internal bleeding. Basically, the blood is leaking outside the artery in that circumstance, and usually that's associated with severe pain. Next slide. Dissection, on the other hand, is different. Dissection means that there's a tear in the wall of the artery or the aorta, and blood then flows between those layers. And what that does is then, as you can see in the picture in black and white, I don't have an arrow to show you, but you see where I labeled false lumen and true lumen, and then there's a line in between them. So that is a dissection where the inner liner has sheared off. And what that does is a couple of things. One is it can weaken the wall of the false lumen, the artery or the aorta on that side becomes weaker, and it can bulge out over time and become an aneurysm, or it can cut off blood flow to branch arteries that are coming off that main artery, or can block the artery itself. So that's why dissections are problematic, either because they weaken the artery, they can cause rupture, or like I said, they can occlude the artery or block it off. Depending on where they are, there's different terminology, but basically you reference it to where it is in the artery. And then, if it's in the aorta, you'll say, is it in the ascending aorta or the descending aorta, or commonly you'll hear the terminology type A and type B dissections. Next slide. And you can have aneurysms and dissections in the same person and not necessarily in the same arteries. So this is a CT scan. It's a side view of a cut of somebody's aorta, showing you that they have an aneurysm on one side, say they have an ascending aneurysm, and then they have a descending thoracic aortic dissection where the arrow says dissection. And this is a person who had Marfan syndrome. So you can see that both of them can coexist in a person. Next slide. You've seen this picture. This is from Gustavo Oderich's paper, where a few years ago he talked about the distribution of arteriopathy in vascular EDS. And then on the right-hand side is our paper from 2019, where we also looked at the same thing. But consistently, you can see that the arteries that are involved in vascular EDS are fairly similar in both experiences. And now we're seeing this also in the VEDS collaborative research study, which many of you are parts of that study now, where we're, again, getting a lot of information about what arteries are involved. But you can see that the aorta can be involved, but to a much lesser extent than what we call the mesenteric arteries or the iliac arteries in people with vascular EDS. Next slide. This is the University of Washington experience with Loeys-Dietz, where we looked at 63 people with Loeys-Dietz over the last 20 years. And again, you can see the distribution of arteries that are involved, where most commonly it affects the carotid arteries and the common iliac arteries on both sides of that spectrum, and then less so in the other arteries themselves. And you can also see the tortuosity in that picture on the right. Next slide. We also asked the question about how often do we see this in Marfan syndrome, because classically, the classic teaching is that Marfan syndrome only affects the ascending aorta or the aortic root specifically, but we know better, and we know now that it can affect any part of the arteries. So on almost 400 individuals with Marfan syndrome at the University of Washington experience, you can see that 13% had affected arteries, and this was 104 arteries in 52 individuals. So again, each person can have one or more artery that is affected. In terms of the most common locations in Marfan syndrome, what we've seen in people who have arteries that are involved, the iliac arteries and the subclavian arteries and the carotids were the most common, but you can see, again, if in this graph, you can see that there's other arteries that can be affected to a lesser extent. Next slide. So in terms of repair principles, we do know that most aneurysms and dissections can be managed non-operatively. And I think this is a very important concept to make, because when people hear that they have a dissection or aneurysm, that is obviously a worrisome diagnosis, but it's important to recognize that most of them can be managed non-operatively. But when we do repair them, we always want to weigh the risk of surgery and the benefit of surgery. And the benefit is to prevent the risk of aneurysm rupture. So once the aneurysm reaches a certain size that it is at risk for rupture, then the benefit of surgery becomes more important than the risk of surgery. And so we base that based on size criteria, and I'll show you how we come to these size criteria. And then for dissections, if there's blockage of the arteries or if there's rupture, obviously, then they need to be repaired. We don't have specific guidelines for vascular EDS, low EDS, and Marfan syndrome specifically, but we do have general guidelines that are derived from population studies among people who don't have these diagnoses. Next slide. Other principles that are important to understand is that elective surgery has better outcomes than emergency surgery. This is very important because sometimes people say, well, what if we just wait until we have a rupture and then do the repair? Well, we know from population data that people who have ruptured aneurysms do worse than people who have elective repair of their aneurysms. So again, ideally, you want to detect these things if they are there, and you want to have a discussion about repair so you can do these in what we call an elective setting, meaning things are controlled, we have a team that's set up, it's not in the middle of the night, and we have everything we have in our system to make this a very successful surgery. And again, the data support that. Next slide. So aortic aneurysms, this is specifically for abdominal aortic aneurysms, not ascending. You've heard a lot about the ascending and root aneurysm thresholds, but this is for abdominal aortic aneurysms. And you can see from population studies the number of 5.5 centimeters, that's when the abdominal aortic aneurysm reaches 5.5 centimeters. That's when the risk of rupture starts going up. And that is when we recommend repair in the general population. This is a great starting point for people who have a named condition, meaning vascular EDS, low EDS, and Marfan syndrome. And again, there are no specific guidelines, but in general, it seems like people with Marfan syndrome can tolerate up to 5.5 centimeters before repair. Whereas people with vascular EDS, in my experience, I offer repair at a smaller size, and that's both myself and Jim Black from the East Coast. We think that repair at a smaller size is more beneficial. And again, we'll have some data coming up on that in the next 6 months or so. Next slide. For visceral aneurysms, these are the aneurysms that supply the blood vessels to the intestines, for example, and the kidney arteries. There are guidelines that has been established by the Society for Vascular Surgery, and these are great guidelines that anchor our discussion when we talk about repair. These again are based on population studies, so not specifically for people with named diagnoses, but it makes our discussion a lot easier. So for example, when you look at gastric and gastroepiploic arteries, it recommends repair regardless of size. And so again, we have this discussion if somebody has these and anchor our discussions in these size criteria and make a decision that is individualized with the person who has these aneurysms. Next slide. I do follow people with vascular surveillance. You heard about that from Dr. Young, who talked about the surveillance for the aortic root. Similarly, for the rest of the vasculature, I like to get a baseline CT scan or MRI from the neck to the pelvis at the first time when I meet somebody. And then if there's pathology present, I'll repeat it every 6 months, usually with duplex. This is ultrasound or MRI because we're trying to avoid radiation exposure when we can. And if we are planning on an operation, then my preference would be a CT scan in that circumstance. Of course, there are circumstances in which surveillance fails. Those are people who have carotid cavernous fistulas or spontaneous hemorrhages from branch vessels or dissections. These are instances in which we can't predict them based on imaging yet. So those are things that surveillance will not predict, but surveillance will show us aneurysms and will show us growth of aneurysms over time. Next slide. Medical management, just touching on that very briefly, that if there's hypertension, we want to treat it. If somebody smokes, they need to quit smoking, because smoking is one of the most detrimental things you can do for your arteries. I do recommend daily walking and moderate exercise, practicing a healthy diet, lifestyle, and low-dose aspirin is in the circumstances in which people have dissections, and then avoiding fluoroquinolones, which you've heard about in the medical management side. Next slide. So when we talk about endovascular repair, you've heard two terms. You've heard embolization and you've heard stenting. But basically, these are what we call minimally invasive procedures. We perform them through accessing the femoral artery in the groin area, where we put in our wires and our catheters and are able to do the embolization or the stenting. It requires what we call a hybrid room. You can see the picture on the bottom right, where we have all this machinery, and we can use X-ray to see, to navigate our way into these arteries. Next slide. So when we say embolization, what we're talking about is where we are putting synthetic material into the artery branch or the saccular aneurysm to cut off the blood flow in that artery. These are usually arteries that we can sacrifice. So for example, splenic arteries, these are the arteries that feed the spleen, are perfect arteries to use embolization material for them. And these can be done by a vascular surgeon or interventional radiologist, depending on the institution where you go and the local expertise. Next slide. The next slide is going to show you an example of embolizing a large subclavian artery aneurysm in a patient with vascular EDS. And then on the right-hand side is, as I mentioned, splenic artery embolization. And we, as of not even 4 weeks ago, presented data on 88 patients with vascular EDS who've had splenic artery aneurysms, and a third of them needed interventions, and everybody who's had embolizations had that done successfully. So again, for example, splenic arteries are very amenable to embolizations, and it can be done with minimal risk to the patient. Next slide. The stents, on the other hand, these are examples of arterial stents. And when you talk about stents, we talk about there's bare metal stents versus covered stents. And the bare metal stents are something that we use to open up an artery that is blocked. Usually that's not what we're going to use in people with vascular EDS, low EDS, or Marfan syndrome. If we're going to use them, we're going to use covered stents, which function as a liner inside the artery. And this is in circumstances in which you have to keep or preserve the circulation. So you can't just embolize the artery. So you have to use covered stents. And again, we've used these successfully in circumstances where we had to. The next slide, please. And this is just a comment on access sites, because as I said, you go through the femoral artery when we do these. And so we have to be careful with the way we close the femoral artery so that we don't have pseudoaneurysms afterwards. And my impression is that people with vascular EDS, my preference is that we perform an open exposure if we're using what we call large sheaths. So really the size of the catheter and the sheath that we are putting in dictates whether or not we need to do an open exposure and repair, just like this one described by Dr. Black's group a few years ago, or if we can just do it through the skin, what that's called percutaneous. Next slide. And this is an example of how I show this when I teach about how these exposures and repairs are done at different talks. You can see these are pictures of somebody's femoral artery, and this is a great way to enforce the artery and not have any complications after this kind of procedure. Next slide. So I'm going to run through quickly. These are, again, the arterial tree, if you will, from top to bottom. So we're just going to run through and give you examples of how they're managed. Next slide. So carotid cavernous fistulas. This is usually managed by neurointerventionalists, not by vascular surgeons. And basically, these are the ones that form behind the eye, and it's a abnormal communication between the carotid artery and the vein in that area. And these are usually managed with embolization. So the yellow arrow shows you the embolization material that has been blocking that area, the carotid cavernous fistula. So that is how that's treated. Next slide. This is now the extracranial. So this is the carotid artery and vertebral arteries in the neck. These are usually, in the majority of circumstances, we manage them non-operatively. And on occasions, we do have to put a stent in, for example, to manage it. And in extreme circumstances, we've heard of cases where people have used embolization material in those circumstances. The book on the right, The Carotid and Vertebral Artery Dissections by Jody Dodds, is actually a great book. She summarized both the medical knowledge about how to approach this, as well as interlace that with stories of people who've had carotid and vertebral artery dissections. So it is worth a read if that's something you're interested in. Next slide. This is important in terms of data. The question always comes up if we want to use aspirin or antiplatelet therapy versus anticoagulation, that's Coumadin, in carotid artery dissections or vertebral artery dissections. So we have data from a randomized trial. This is, again, general population, where they compared antiplatelet versus anticoagulation. And the results were that there was no difference. And therefore, I personally recommend antiplatelet therapy, and I base it on that study. Next slide. There are circumstances in which there are aneurysms, like I said, and these require an open repair. And like I said, in extreme circumstances is a case of a woman who had embolization of her carotid artery. So that can be done as well. Next slide. Subclavian arteries, I've shown you one picture of somebody that I've embolized the subclavian artery on, but also there are reports of subclavian artery ruptures that were treated with stenting. And then on the picture on the right is somebody who I had to do a bypass on. This is somebody who had Ehlers-Danlos syndrome, not vascular subtype, but another subtype who needed an open operation. Next slide. This is, again, an example of what that looks like in somebody with Marfan syndrome. And you can see that in this circumstance, we had to do what we call a sternotomy and then extend it to over the clavicle, above the clavicle, and then replace it. And you can see the arrow in the middle picture shows you the aneurysm, and then on the right picture shows you the graft itself. Next slide. This is a different location of a subclavian artery aneurysm in somebody where it's further out towards beyond the clavicle itself. The next picture. And again, those can be treated. We treated him with an incision again above the clavicle, and we're able to treat that. That's the, if you can go to the next slide, please. And again, you can see it looks like a ball basically, and we replace it with that Dacron graft. So picture B shows you the aneurysm. Picture C shows you the aneurysm once it's open, and then D, the Dacron material. Next slide. The celiac artery aneurysms and dissections, again, frequently these are present in our population, and most of them can be managed medically. And on rare circumstances, we do embolization for those. Next slide. Hepatic arteries and splenic arteries. Again, I've told you splenic arteries do really well with embolization. Hepatic arteries, on the other hand, frequently we want to keep the flow, so we use stents for treating those. Next slide. In terms of data, again, for the superior mesenteric artery dissections, we do know that medical therapy works well, and what we had found is that in a majority of circumstances, when there are dissections, we can treat them with, again, antiplatelet therapy and controlling hypertension, and very few circumstances that we need to do an intervention for these. So that's actually good information to know. And again, this is for the general population, not specifically for vascular EDS or Loeys-Dietz. Next slide. Common iliac artery aneurysms, you heard, I've said it's, if we're going to see it in people with Marfan syndrome, we will see frequently common iliac artery aneurysms. And then again, very frequently, we'll see this in people with vascular EDS. So I'm showing you the yellow arrows show you where that is located. And that the inverted Y that you're seeing, that's about belly button level or umbilicus level. So just, and to put it in perspective. And again, those in the majority of circumstances, we treat them with open operations. And we've done a few of these here at the University of Washington now. And sometimes, depending on the underlying mutation, we can use the endovascular operation. That is still controversial, but again, with the natural history studies, we'll have more data as to who is the appropriate candidate for that kind of approach. Next slide. External iliac arteries, these are the branches of the common iliac artery. These branches tend to be amenable for stenting. And again, there are certain practices that we have to do to be careful when we put the stents where, for example, we don't balloon them or stretch the artery beyond what it needs to be stretched. But it can be done safely, again, with the precautions that we teach in terms of access and repair of the access itself. So with that, I'm going to come to a close. Basically, I'm hoping that you've walked away knowing the difference between aneurysms and dissections. We can go to the next slide. And you have a sense of the distribution of arterial pathology, and that's why we do surveillance, to look for them. And then now you should be more familiar with the terms embolization and stenting, and just have a better understanding of open surgical repair in these cases. And I'd love to have your questions. We'll go to the next slide. I just want to show our group of people that I am very thankful for to work with. Next slide, please. And this is a lot of people in the vascular EDS community, specifically I'm showing them here. And because of, and everybody else that I've worked with all, vascular EDS, Marfan syndrome, Loeys-Dietz, a lot of my patients have these conditions, and I've learned a lot from them, and we've learned a lot together. And again, I appreciate you being here and to listen in, and looking forward to your questions, and we can stop sharing.
Well, I'm going to leave that up because I don't think you're on video in this way. They don't have to look at me, but they can look at your
Okay,
slide.
perfect.
Okay. I'm going to just ask, I'm just so we can get back on time. I did have one question for you here. Does Loeys Dietz change if you go through the femoral artery or open embolization due to more fragile tissue?
So with Loeys Dietz, there's 5 subtypes that we know about, right? We know about TGF beta receptor 1 and 2, SMAD3, TGF beta 2, and TGF beta 3. TGF beta receptor 1 and 2 seem to have more fragile tissue compared to SMAD3, for example. So I'm comfortable saying that people who have SMAD3 tissue, their tissue behaves similarly to those who have Marfan syndrome, whereas people who have TGF beta receptor 1 and 2, their tissue perhaps is more fragile, similar to vascular EDS. So again, if we're going to go through the femoral artery and we're going to use a large sheath, so for example, you hear us talk about sizes, and sheath sizes come in French, and they're called 7 French, for example, or 8 French. That's kind of relatively larger than, for example, a 4 French, which is smaller. So if we're going to go up in the size, then my preference would be to do an open exposure and repair the artery directly under direct vision. Whereas if we're using something very small, then I feel comfortable saying we can use it what we call percutaneously, where we go through the skin and then we pull the sheath out and hold pressure to get the artery to seal on its own. So there is variation, and that's why I think it's important to know what kind of variant we're dealing with, what kind of mutation we're dealing with.